Hi, everyone. Welcome back to Plum Peeps. Furf and I are super excited to be meeting again this week and have another recording. As we always say, one of our favorite episodes are the Fellows Case Files. And Furf, how excited are you today for our next one?
So excited. This is my favorite. And honestly, now it's like super fun because for a while we were asking people what cool cases they have. Now we just have cases pouring in and people are seeing interesting patients around the country and letting us know. So I love to hear about these. And I feel like I'm expanding my horizons. We've had some histoplasmosis, fibrosing mediastinitis, things that are pathogens that are in places where I don't see them as much. So I feel like it's really helpful for me not to forget about these. Although today we're going just around the corner from where I am. Going to UMass Memorial Medical Center or UMass Chan School of Medicine, and we're really excited to have another great case. So first, let's meet our guest. We have Dr. Jen Kodela. Jen completed her residency training at UMass Memorial Medical Center and is currently a third-year PCCM fellow at UMass Chan. Welcome to Phone Peeps, Jen.
Hey, thank you so much for having me.
Awesome, Jen. We're so excited to have you and excited to introduce another co-fellow, Dr. Ariel McKenna. Ariel completed her residency training at Maine Medical Center and is also currently a third-year PCCM fellow at UMass Chan. Ariel, we are super excited to have you joining today as well.
Thank you so much for having us. Super excited to be here. I listen to you guys all the time.
Oh, thanks for that. We appreciate it for sure. And lastly, we have Dr. Will Wong. Will is an assistant professor of medicine and is the program director of the Pulmonary and Critical Care Medicine Fellowship at UMass Chan. Thanks for coming on the show, Will. Before we dive into the case, just a reminder for everyone listening, this podcast is not meant to be used for specific medical advice. The views we express today do not reflect the opinions or policies of our respective employers necessarily. The case we will present today is HIPAA compliant, and there may be some details that are changed here or there to protect the privacy of our patient. So with that, let's get started. Jen, I think that you had a patient that you met that you wanted to talk to us about. Can you tell us how they initially came in?
Yeah, absolutely. So, our patient was admitted to one of our inpatient services at UMass Chan. She's a 75-year-old woman and she's presenting with an acute on chronic shortness of breath, cough, left sided chest pain, and rash. She's had about 7 months of progressive dyspnea, now with 2 months of productive cough and several weeks of left sided chest pain and rash. And I'll give you a little bit more of her history because she's had really ongoing troubles for several months now. So, she's been in and out of both urgent care and outpatient offices over the past several months for these symptoms. She's had multiple images that have been taken through this time, including chest x-rays and a CTPE. And these showed slow progression from a left lower lobe infiltrate to bibasilar infiltrates. She's received multiple antibiotic courses for this for presumed pneumonia, including augmentin, azithromycin, and levaquin. Also received some asthma-directed therapy, really adjustments to inhalers, but no steroids. And despite all these interventions, she continued to worsen. By December, about a month before we met her, she was admitted to an outside hospital for continued worsening. On that admission, she had stable vitals, a nonfocal exam, mild leukocytosis, but the infectious workup was bland. She received broad spectrum antibiotics again for presumed pneumonia, and they did pursue a bronchoscopy at that time. The BAL showed a cell count of with 66% neutrophils, 14% eosinophils, with negative cultures and cytology. So at the time, she was discharged again with a diagnosis of pneumonia on a 10-day course of levaquin and a new exertional oxygen requirement of 2 liters. So now we're meeting her about a month after that with continued progression of symptoms.
Thanks so much, Jen, for sharing that. And I think it's important to take a quick pause here. And based on the information you provided, I would say we have an older age woman with acute and chronic dyspnea, cough and rash with progressive symptoms and euhypoxia, despite various antimicrobial treatments that you mentioned. And I think the five of us right now are probably having a very broad differential. And at least I'm focusing right now still on infectious and potentially inflammatory etiologies. And I think regarding infectious etiologies, thinking of a community-acquired pneumonia with possible development of a parapneumonic effusion or empyema could have been considered. However, Jen, that the time course just wouldn't necessarily fit with that at this time. Other etiologies, we're thinking that what is a substrate? She does have diabetes, in a sense, somewhat immunosuppressed. Does she have TB or other fungal infections that should be considered? We had another fellow's case files with a patient who had uncontrolled diabetes and ended up having mucor. So that's something that I remember from the cases that we've done. The left-sided chest pain raises concern for some pleurisy, which could be secondary to a systemic process such as lupus or rheumatoid arthritis. And I think additional inflammatory or autoimmune conditions, given the pulmonary and skin findings that you have described, can include a variety of connective tissue disorders with associated ILD. I think I just thinking ahead too, right? In physical exam, she's had these progressive symptoms, but now I hear rash and chest pain. I want to definitely rule out that this isn't zoster or shingles that's now accompanying her progressive symptoms. And I think one last thing I'll comment on that I think you had a nice piece of information was the bronchoscopy with BAL that she had done with 14% eosinophils that expands my differential as well slightly to include more of a hypersensitivity pneumonitis that I could be thinking about, as well as potential eosinophilic pneumonia.
Yeah, Christina, I totally agree with your way you're thinking about it. These are really interesting cases for a couple reasons. One, I really hate when someone comes in with what we think is acute and then is leaving on an oxygen requirement. That always makes me worried that I'm missing something. Obviously, sometimes people just need some home oxygen and time to recover, but it leaves me scratching my head a little bit. And then the eosinophils, as you pointed out, are super interesting. If you have a bacterial pneumonia, usually lots of neutrophils, and usually that eosinophil is suppressed by the inflammatory reaction, thinking about whether or not you have eosinophilic pneumonia, like you said, reaction to a bug that maybe causes eosinophilia, and sometimes parasites and certain fungal infections, or even vasculitic infections, that some vasculitides that lead to eosinophilia and the BAL are all things that I'm still thinking about now.
Yeah, such great points for. And I think having said that, Jen, would you mind giving us some more background and tell us about her presenting physical exam?
Absolutely. So she has a past medical history that was notable for OSA on CPAP. She has asthma that's been very well controlled for years. She can't recall the last time a flare required prednisone. Osteoarthritis, type 2 diabetes, and hyperlipidemia. Surgical history included a total abdominal hysterectomy and cholecystectomy. Her medications include lisinopril, HCTZ, atenolol, nystatin powder, albuterol, atorvastatin, and loratadine. Her history was only remarkable for cirrhosis in her father. And in terms of her social history, she was born in New York. She previously lived in Puerto Rico, but has been living within the United States for the past 13 years and primarily within New England. She's been a homemaker her entire life. She's had no significant environmental or occupational exposures that we noted, and no changes to her home environment. In terms of her exams, on presentation, her vitals, she had a temperature of 100.6. She was otherwise hemodynamically stable and oxygenating well on room air at 96%. She was in no distress. Her HENT and cardiovascular exam were without notable abnormalities. The pulmonary exam, she was speaking in full sentences. She had no accessory muscle use. She did have fine bibasilar crackles, but no wheezing or rhonchi. Her abdominal exam was benign. On musculoskeletal exam, she had pitting edema over the dorsum of both hands and her lower extremities extending to about the mid-calf. Strength and sensation were both preserved. And neurologically, she was alert, oriented, had no vocal deficits. The most pertinent finding, I think, was her skin on the initial exam, where she had evidence of these thin plaque pink papules that were coalescing into thin plaques on the extensor forearms and lateral posterior upper arms. There's no significant epidermal change. The pink papules were coalescing into plaques at bilateral superior lateral hips, consistent with a Holster sign, and there's no significant epidermal change there either. There were pink, slightly lichenified thin plaques with mild scale along the medial gluteal cleft as well. And then I can give you some lab work from the initial labs. She had a mild leukocytosis and normal cytic anemia with a white count of 15 and hemoglobin of 9.8. The differential was notable for an eosinophilia of about 500. She additionally had a mild hyponatremia. Otherwise, her kidney function, electrolytes, LFTs, and BNP were within normal limits. And she did have some additional infectious workup that was sent up front, including a beta-D-glucan, galactomannan, taxocarin, and strongoloides, all of which were negative.
That's great. So a great evaluation to come in and a lot of information to work with. I think Christina mentioned the infectious and inflammatory etiologies that we're all considering going in, and I think we can hone in on some of them. as we're having these lab values and exam. This is a type of presentation that certainly first things that pop into my head are things like eosinophilic pneumonia, organized pneumonia, where the classic story is somebody comes in with recurrent pneumonia presentations, maybe gets better, maybe gets antibiotics, maybe gets steroids, it improves, they go home, they come back with the same thing. Christina mentioned hypersensitivity pneumonitis, which can do that too if people are going home back to an exposure that hasn't been removed out of the house in the first place. A couple specific things, she certainly has some inflammatory reaction going on. She's febrile, she has these infiltrates. So we really need to hone in on what the cause of this is. And I think we're going to end up getting a lot more tests to try to identify that a little bit more specifically. Her past medical history of the asthma is something that I know with the eosinophils that you mentioned. She has a peripheral eosinophilia now. She has a BAL eosinophilia. Certainly, we see eosinophils most commonly in pulmonary in the context of asthma. That being said, we always have to rule out mimics. And this history doesn't really seem consistent with just a classic eosinophilic allergic asthma phenotype. So I wonder about that diagnosis in the past. And if we're going to hone in on something that's more specific that we're going to be looking at, we've talked about ABPA, you mentioned sending a strongyloides. These are the types of things that can lead to the eosinophils going up and either co-present with asthma or mimic it a little bit. You mentioned a rash. So certainly I am not an expert on rashes. And I like how both you describe what you're seeing here, but then you say consistent with the Holster sign. So my test taking brain remembers that Holster sign is something that we think about in scleroderma, that we think about in dermatomyositis a little bit less commonly than we think about the other signs that people often report. So we think about Gotchen's papules, heliotrope rash, or Shaw sign. Holster sign is sort of this violaceous rash over the lateral hips that can also be described in dermatomyositis. So I add something like that to my differential. And then the other papules and plaques that you are describing almost sound to me like psoriatic, but I would certainly want a dermatologist or somebody who has more experience to take a look at them. So broad differential, I think we're thinking a lot more inflammatory autoimmune things now, as opposed to pure infectious, but we could certainly send some more infectious studies as well. And to summarize, we have a 75-year-old woman with acute on chronic dyspnea, cough, left side chest pain, and a rash, with pulmonary exam findings notable for bibasilar crackles. Ariel, I was wondering at this point if you could talk about what kind of imaging and tests we'd want to get next. I think this person is certainly going to undergo more workup. And if you could tell us about the modalities you prefer and why, that'd be great.
Of course. So we're seeing this woman in our inpatient setting, and giving the report of prior abnormalities on chest imaging, a chest CT would allow us to evaluate the parenchyma, as well as better appreciate any adenopathy that may not have been apparent on chest x-ray. You could also consider a high-res CT with inspiratory and expiratory films for patients who have not had one. Obtaining inspiratory and expiratory films can help to evaluate lung volumes, as well as for air trapping or obstruction to airflow in the smaller airways. Evidence of air trapping is more common in certain subtypes of ILD, such as hypersensitivity pneumonitis. Obviously, a CT angiogram would help rule out pulmonary vascular disease, such as PE, but that was lower on our differential based on the presentation and physical exam findings Jen mentioned earlier. Giving her skin findings, like you said, it would be helpful for dermatology to evaluate and pursue a skin biopsy, as the results really could help with our diagnosis. I would also obtain an echo on her as well and consider pulmonary function tests to evaluate for any restriction or gas transfer defect with lung volumes and DLCO, respectively.
Thanks so much, Ariel. And I really loved your teaching points of getting both an inspiratory and expiratory film. And I know when we had our top consult series too, I know Sonia Danak also mentioned when we're thinking about someone with ILD, you can also get prone films as well. Different scenarios, obviously, patient context is going to be important. But yeah, thank you for walking us through that and telling us your thought process. And I'm sure that she had, if not all, some of these tests. So Ariel, do you mind just telling us what diagnostics were obtained and there was some of the results?
Of course. So the first imaging test that we obtained was a non-con CT of her chest. This did show dense bibasilar ground glass opacities and consolidations, with a peribronchovascular distribution with some areas of subpleural sparing, septal thickening, mild traction bronchiectasis, and mediastinal inhaler adenopathy. Compared to imaging from a month ago, the ground glass opacities actually appear more dense and even nodular in some areas. There's also now more involvement of both lungs and more extensive involvement in the lower lobes. An echo was also obtained, and although there were limited windows, it does show normal LV and RV size with low normal LV systolic function with an EF of 50 to 55%. There was no evidence of diastolic dysfunction or valvular pathologies. She did go on to have 2 skin biopsy specimens obtained. The first specimen showed direct immunofluorescence that was negative for IgG, IgA, IgM, C3, and fibrinogen, with a dermal and perivascular neutrophilic inflammatory infiltrate. The second specimen showed urticarial vasculitis and leukocytoclastic vasculitis involving the superficial small capillary-sized blood vessels with perivascular lymphocytic infiltrate and numerous eosinophils. So basically, there was a lot of inflammation, but one thing I wanted to point out and expand on is the leukocytoclastic vasculitis. This is a small vessel vasculitis of the dermal capillaries and venules with inflammation predominantly comprised of neutrophils. It can be idiopathic and isolated to the skin, however, it can also be associated with an underlying disease or systemic vasculitis. Associated conditions to really consider would be infection, drug reaction, malignancy, and autoimmune disorders.
Yeah, thanks for that. We do a lot of data interpretation in pulmonary critical care. I think the most common one we're doing is chest X-ray. And when we're teaching chest X-ray, I usually say you can describe what you can then consolidate that into terminology that we use more frequently. So you might see white in one area, black in another. Then you could say that's alveolar infiltrates. That's the words we give to that. And then you could put it all together and say, I think this is pulmonary edema. I think with biopsies, it's really important to put things into context because a lot of times we get something reported back that just says you have perivascular neutrophilic inflammation with eosinophils. And then maybe someone puts it together as leukocytoclastic vasculitis. And then that's the time when it's really important to get on the phone with the pathologist and say, okay, but what is that? When do you see it? And what are the conditions that I need to worry about that associate with it? So I think we have a number of things to chase down here. And then the other thing I wanted to point out is you talked about the CAT scan and some findings, subpleural sparing, septal thickening, mild traction bronchiectasis, painting this picture of active inflammation with ground glass opacities, but also maybe some signs of starting to have fibrosis with the traction bronchiectasis and septal thickening. And when we think about a CAT scan that has interstitial lung abnormalities, we should be trying to categorize it right away into, does this look like it's an idiopathic pulmonary fibrosis or more of an inflammatory alternative diagnosis? And it certainly sounds like we're more in that alternative diagnosis. So a lot of insights here. Jen, I think as we're encountering this case, I'm sure you're taking all this data and stepping back and reframing your differential. So I was hoping you could share about how you were thinking about the patient after you had these results and what additional testing you were thinking about.
Yeah, absolutely. So overall, as we reviewed her serial images, we were most concerned about an underlying ILD. And then when you took in the context of her symptoms, the trajectory of her course, her exam, and the biopsy findings, we were suspecting an underlying autoimmune disease as a potentially unifying diagnosis. So with that in mind, we sent a pretty broad serologic workup. This included ANA, anti-centromere, SSA, SSB, rheumatoid factor, anti-Jo. She got complement levels, CCP, ANCA with reflex to MPO and PR3, an SCL70, hepatitis panel, HLA-B27, and a quant goal. All of this was negative. Inflammatory markers were additionally sent, and she had an elevated CRP at 101 and ESR at 59. CK was additionally within normal limit, aldolase was 8.4, and an immunoglobulin panel was within normal limit. We did also send off a full myositis panel, and the tricky thing for us is that these results don't come back for 5 to 7 days. It can be a rather extended time while we're waiting. So we were continuing to pursue additional workup as we were waiting for this.
Thanks so much, Jen. And so many important labs that were sent. And I feel like sometimes when I'm trying to think of it, like nursing's right away, what can I go ahead and send the labs? I'm like, just give me like a few more minutes. I need to think of everything so we can just send all at one time and you don't have to repeat anything. So great diagnostic workup that was sent, and agree about the myositis panel. Right, it does take, I think at different institutions, it's often a send out and can take, as you mentioned, up to a week before you get the results back. So in that time, you're trying to decide what further diagnostics need to be done. Should I start treatment based on what I think the myositis panel is going to show? So great information so far. And I think at this point, probably someone has mentioned, either you or someone on your team is probably asking again, should a repeat bronchoscopy with a BAL and consideration of transbronchial biopsies be done for this patient? And would love to hear your approach on whether or not you think this is indicated. And if you could describe the utility of a transbronchial biopsy in the workup of undifferentiated ILD such as this patient.
Sure. Thanks, Christina. With bronchoscopy, as with any procedure, the question I ask myself is, will this change management? As we mentioned, the hope in the workup of any interstitial lung disease is that we use a blend of the clinical presentation, any supportive serological data, and the imaging to craft our best differential diagnosis. If on that short list of differentials that includes a strong UIP pattern, we try not to push for a biopsy because the usual combination of that honeycombing, traction bronchiectasis, and that subpleural and apical basilar distribution often points to IPF, which unfortunately there isn't much treatment for. So even if we do get an answer, it doesn't change our management. On the other hand, if we do see a lot of ground glass opacity, something that indicates active inflammation, I'm more likely to reach for the forceps or the cryoprobe because I might get something that I can potentially treat. And the benefits may outweigh the potential complications of pneumothorax, bleeding, or hypoxemia. For this lady, given an indeterminate workup thus far and with her persistent infiltrates that have been unresponsive to multiple rounds of antibiotics, it's reasonable to suspect something such as an organizing pneumonia, a partially treated infection, or inflammatory disorder. Before we commit to a patient to potentially months of steroids, it would be nice to rule out fungal diseases or anything that can be exacerbated by prednisone.
Yeah, completely agree. And I love that approach. Takes in both what we were talking about of looking at your CT and saying, do we have a diagnosis here? There's a UIP pattern, it all fits, and then just weighing the risk and benefit. And I think within that is determining the procedure. You mentioned the cryobiopsy. I think if you have a place where people are doing cryobiopsy and comfortable with it, this is a really nice way to get a large piece of tissue and be able to make your diagnosis more than you're normally getting, like your forceps transbronchial, but avoiding VATS with wedge biopsy. That being said, if the patient is relatively healthy and can tolerate a VAT, sometimes that's the easiest way to go. You get your full diagnosis as long as there's a minimal risk of other side effects. That being, it's a larger procedure. We definitely have to talk to our patients about it. And in an older patient like this, who's already on oxygen, we do worry about the recovery a little bit. There's also some data out there that patients who come in and get an unplanned VATS biopsy often end up having a little bit of a rocky course. So we like to try to stabilize them first and send them out or go for a less invasive approach. So Ariel, I'm curious what happened next if your team decided to proceed with any of these diagnostic workups and what they found.
Yeah, so ultimately the decision was to pursue this testing. She underwent a bronchoscopy with BAL to the left lower lobe and a transbronchial cryobiopsy to the right lower lobe. She also had an EBIS with TBNA to stations 4R, 11R, and 7. The cell count in the BAL showed 70% neutrophils, 22% eosinophils, 4% monocytes, 3% basophils, and 1% lymphocytes. Bacterial, fungal, and AFB cultures were all negative. Cytology and cytometry from the BAL and from all 3 lymph nodes were negative. The right lower lobe tissue biopsy revealed alveolar lung tissue with fibroblastic plugs and alveolar sacs, thickening of alveolar septa with chronic and acute inflammation consistent with organizing pneumonia. There was no definitive granuloma or vasculitis identified, and immunostains for adenovirus, CMV, HSV1 and 2 are all negative. A Gamori methanamine silver stain is negative for fungal organisms.
Thanks, Ariel. Before all this, the differential diagnosis included partially treated pneumonia, eosinophilic pneumonia, organizing pneumonia, connective tissue disease related ILD, and less likely malignancy. The DOs remained elevated on each BAL, and generally when you see that they're greater than 25%, we suspect acute or chronic eosinophilic pneumonia, drug-induced pneumonitis, or vasculitis. But with moderate elevation, we should consider sarcoid, Langerhans, or connective tissue diseases. A neutrophilic dominant pattern can be seen in IPF, hypersensitivity, as well as cryptogenic organizing pneumonia. For this case, the actual tissue returning as organizing pneumonia was extremely helpful. That helped the team commit to treatment with long-term steroids.
Thanks, Will, for walking us through that and bringing up a couple other differentials that we should be considering. We've said so far in the case that there's evidence of both peripheral as well as pulmonary eosinophilia, as Firth mentioned earlier. Ariel walked us through what leukocytoclastic vasculitis on the derm biopsy showed, and she has evidence of organizing pneumonia on transbronchial. And otherwise, Jen, you mentioned negative workup for infectious, malignant, or rheumatologic etiologies thus far. But I know that you said I think we're still missing one important diagnostic test, and you mentioned the myositis panel, which could take about 5 to 7 days. And I'm wondering if this time, Jen, if you can reveal if you have any results on that and if that changed how your team approached further management.
Yeah, so a bit of a cliffhanger, but we did get the myositis panel results while she was still inpatient, and it was positive for the PL12 antibody. So she ultimately received a diagnosis of PL12 antisynthetase syndrome with lung and skin involvement. She was started on prednisone on about day 9 of hospitalization after the bronch was completed. And then she was later pulsed at about day 15 because of minimal response to the initial steroid dosing. Ultimately, she was discharged on prednisone 60 milligrams with a plan for a slow taper with PJP prophylaxis and GI protection with a PPI. There were additional plans to consider initiation of rituximab as an outpatient.
Thanks, Jen. Super interesting. We have mentioned on the show a lot, tissue is often the issue, the old adage. And in this case, it's pretty interesting because we had organizing pneumonia on the tissue. We almost certainly were going to treat this patient with steroids. But the myositis panel that comes back, which could often go overlooked. If somebody doesn't click it, patient doesn't have muscle complaints, just doesn't get sent, or the patient gets discharged and somebody misses it on follow-up, really changes the entire diagnosis. We're now thinking about not just an isolated organized pneumonia or a COP pattern, but we have a more systemic, unifying diagnosis for all of her complaints. And that makes us feel a lot more comfortable about things like a steroid pulse, things like planning rituximab, as opposed to just calling this refractory organized pneumonia if it doesn't respond initially. You mentioned antisynthetase syndrome. Super excited that we're bringing it up and talking about it here. This is a syndrome that people are going to hear about when they're in med school and residency, circulate around a lot more when they get into pulmonary fellowship, but I think often misunderstood, and maybe not all the common features are known to people. So I was hoping that we could talk a little bit more about this and familiarize our listeners with antisynthetase syndrome and antisynthetase related ILD. Ariel, could you give us a little bit more details or things that you learned about this from this case?
Absolutely. So, antisynthetase syndrome is an autoimmune disorder characterized by antibodies directed against amino acyl transfer RNA synthetase. This syndrome has historically been grouped with dermatomyositis and polymyositis. However, more recently has been recognized as its own syndrome, as there can be differing characteristics and differing implications for treatment and prognosis. Antisynthetase syndrome is characterized by some combination of ILD, myositis, arthritis, fevers, mechanics hands, severe GERD, and Raynaud's syndrome. The interstitial lung disease can really occur at any point in the disease course, but it notably often precedes manifestations of myositis. Also, the presentation can be mild to rapidly progressive respiratory failure. The diagnostic workup includes high-resolution CT and pulmonary function tests with a trending pulse ox. Lab workup should include typical autoimmune serology that you would send when working up a connective tissue disease ILD. Would highlight, though, that anti-Ro or SSA, as this has been independently associated with antisynthetase syndrome. Also would check CK, aldolase, and specific myositis panel if available. Pulmonary hypertension is a recognized complication in patients with antisynthetase syndrome, so echo may be considered. In a patient with known myositis, and specifically antisynthetase syndrome, a bronchoscopy and biopsy isn't really necessary, as there isn't a specific identifying histologic pattern, but these are often part of the workup in patients with an undifferentiated ILD. And along those lines, muscle biopsy may be performed in patients who do have muscle symptoms. However, it really is done in patients with antisynthetase syndrome, as the muscle symptoms often present late, if at all. There are 8 known antisynthetase antibodies. The most common and more likely recognized is anti-Jo1. This is associated with arthralgias, mechanics hands, and myositis. Less commonly seen but tested in the myositis panel are PL7, PL12, anti-OJ, and anti-EJ. Our patient had PL12 antibody. This subtype is quite rare. It is typically associated with Raynaud's and isolated ILD, and it's associated with much more severe lung involvement and much less muscle involvement compared to anti-Jo.
Ariel, thanks so much for walking us through that. As Verf said, such a common diagnosis and disease that you should be familiar with, specifically in pulmonary fellowship. And Jen, so I know Ariel just did some great kind of teaching points on the clinical manifestations, including extrapulmonary manifestations and diagnostic workup. I think at this point, though, it'd be a good time to just talk about some general approaches to treatment. So I'm wondering if you can share what you learned about treatment for this as well.
Yeah, of course. So treatment in these patients can be tricky. There's no absolute guidance on treatment. This is mainly derived from case reports or series, as there's a lack of prospective data. Corticosteroids remain the mainstay of initial therapy, usually at dosing of 1 mg per kg per day, but that could be higher in more severe presentations. The PL12 variant can be less steroid responsive, and recurrence is frequent with tapering when steroids are used as monotherapy. So, therefore, like in many of the ILDs we see, often additional steroid sparing agents are typically used as well. This includes azathioprine, mycophenolate, tacrolimus, cyclophosphamide, rituximab, but there's little consensus over what the primary agent should be. I will say that typically the agent chosen has to do with the severity or rate of progression, seeing cyclophosphamide and rituximab used in the most severe cases. However, there has been more popularity for the use of rituximab recently. Long-term treatment is guided by close disease monitoring, including spirometry and imaging. And then steroids are tapered once lung disease and or the muscle symptoms stabilize, but there's no exact consensus regarding the rate of steroid taper or the length of immune suppression. I think it's also worth noting that these patients can also be considered for lung transplant as well.
Yeah, definitely. Certainly, if they're not progressing, something to think about early. One thing that I'll add is that sometimes if you have a patient who is getting treated for this, especially if they've had their steroid pulse and still not responding, then in addition of IVIG, certainly still also based on case reporting case series, with not like a large randomized trial guiding, but can help improve symptoms, especially in that sort of like acute initial index presentation. So that's often added to the regimen. And I agree. I feel like there's been this general shift towards rituximab anecdotally. I think often because it's well tolerated, given intermittently as an outpatient, and less side effects and immunosuppression overall than cyclophosphamide. So I feel like people try to steer away from that if possible. But a super fascinating case. Thanks, Jen and Ariel, for walking us through it. Thanks, Will, for sharing your insights. And we have a good approach of thinking about antisynthetase syndrome and a general outline for the treatment of it. And I'm sure we're going to have some more in-depth episodes about how we approach treating these dermatomyositis, polymyositis spectrum diseases. And one additional thing I guess I'll say is I feel like this is interesting. The antisynthetase, it was only really described in the 90s. So it's not like this is a disease that's been known forever. It's an adaptation of old diseases that we knew. But just so as to show, bringing your bedside insights into translational research really can lead to new diagnoses that help improve the management of our patients. This is a great case. We love these case files because we get to meet people from all around the country and at different programs. And UMass Chan is right in my backyard. Certainly I'm in Boston. It's right down the road. We'd love to hear about some things that highlight your experience at UMass Chan, what you like about working there and learning there, and some key things that we should know about the program. Jen, maybe we'll start with you.
Sure. I have been at UMass for all of my postgraduate training, as you mentioned in the introductions, and that's been a very intentional choice. I honestly really love the community and people here, and that's what's kept me here. But in terms of our fellowship specifically, I've also really benefited from the flexibility that we offer. There's room to curate the experience to support specific passions, and for me, that's been medical education. So the fellowship really allows an individual to develop an area of distinction, and I think that's an amazing feature of our program.
That's great. I'm glad we love medical education here. So glad to hear it. Ariel?
Yeah, so one of the incredibly strong features of our program truly is our fearless leader, Will. In the last 3 years I've known him, I've seen him work tirelessly to make this the best program it can be. As trainees, we all have different needs and interests, as Jen was saying, and he really highlights and supports this for all of us individually to help reach our goals and to find our way in this field. He's always open to our feedback and concerns and really strives to accommodate, but also challenge us in this journey of fellowship.
Wow, high praise. I'm sure very well deserved. And for everybody who's going to different programs, certainly the leader at the helm makes a huge difference and influences your experience. We'd love to hear from you.
Thank you, Ariel. I want to make it clear I did not pay her to say that.
Sure.
We'll get at that later.
And I have to say I'm extremely biased because I think this is an amazing program with plenty of opportunities and possibilities. But I think what makes us tick is and makes us great is just that we start with the best ingredients possible. We have a group of lovely human beings who care about the person next to them more than they care about themselves. So when everyone is doing that, it's really hard not to have a fantastic and cohesive team. And it is truly a joy to come to work every day and work with these lovely people.
Thank you all three for sharing. I know you're not biased, but definitely seems, great, amazing people to work with and individualized kind of training plans and great clinical care. And I know those listening today can't see, but the three of y'all are sitting together as we're recording this and just builds that sense of community for us. Definitely appreciate you sharing with us about that today. And as we come to the end of the case, Furf and I like to wrap up each case with a takeaway point. Mine today, I'm going to go to Ariel. When you were talking about antisynthetase syndrome, you mentioned interstitial lung disease can occur at any point in the disease course, but often precedes manifestations of myositis. So that was a good refresher and learning point for me. Furf, what about you?
Yeah, I liked Will's point when he was thinking about doing a biopsy of thinking about the CAT scan and really following the recommended way that we should be interpreting ILD on the CAT scan, which is UIP, probably UIP indeterminate or alternative. If you have UIP, then maybe you don't need to do anything. But in this case, if you're indeterminate or really in an alternative bucket, much more likely to consider the procedures that Will talks us through.
Absolutely. Great point. Ariel, go to you next.
Yeah. So while a biopsy revealing organizing pneumonia is helpful in management, I do think it's really important that the workup shouldn't stop there. You do need to find the overarching problem that is causing the organizing pneumonia. And it's really important in this case because she will need more treatment rather than just steroids.
Absolutely. Jen, anything you want to share with us today?
Yeah, so I'll say, bridging from yours a little bit, Christina, this really highlighted for me that ILD frequently predominates at the presentation of antisynthetase associated ILDs and can be the sole manifestation in the setting of anti-PL12 subtype. So this case really highlighted for me the need for a high index of suspicion when we're faced with an undifferentiated ILD and the importance of pulling together all the small features, the clinical presentation, the course, and the physical exam.
Totally. Thank you for sharing that. And Will, we'll end with you.
So you guys took all the good ones. So mine is, if at first you don't succeed, bronch and bronch again. Yeah, I think with most classic presentations of organizing pneumonia, we often label it as a bacterial pneumonia, throw antibiotics at it, and hope that it gets better this time. But being a good internist and always being able to take a step back, ask more questions, and not being anchored to previous assumptions is one of the most beneficial skills to develop in our careers.
Wow, I love that. Yeah, bronch and bronch again. And definitely, if you're still treating for pneumonia over and over, definitely bronch and bronch again. That's great. I'm taking that forward. Thank you for joining us. This was a real pleasure. Thank you all for listening today. Come back in 2 weeks. We'll have another episode. Make sure that you rate and review us wherever you're listening to this podcast. Visit us on our website. Follow us on Instagram, Twitter, or any other social medias that you're on. This episode was written, produced, and edited by myself and Christina Montemayor. The music's original music by Eric Rogers. And we'll see you next time.
Thank you so much for having us.
Yeah, thank you.